Welcome to the rapid fire respiratory session for finals. We're going to start with probably the most common thing that can ever come up in respiratory. We're going to start with asthma. Asthma is an obstructive, reversible, IgE related inflammatory process of the lungs. It exhibits diurnal variation, and that's one of the key things that you should try to get across to your examiner, that you know this exhibits diurnal variation. You should ask the patient about non-steroidal anti-inflammatory drugs that they might take, naproxen, and therefore any other exacerbating factors. Does any drugs make the chest tighter or anything like that? They might notice, oh yes, when I take things like aspirin and naproxen and stuff like that, it actually does make my chest tight. It can be exacerbated by drugs, exercise, the cold weather. Does it get worse when you're out running, playing sports at school? Has this acute episode that you're probably seeing them for been precipitated by a viral infection? If they do use inhalers for their asthma, how do they use them? Check their technique, and do they keep an asthma diary? And if they don't, you might want to suggest that just for part of your management plan. The patients who are asthmatic will experience shortness of breath, wheeze, accessory muscle use, decreased breath sounds or silent chest. They can have intercostal recession. The patient might be diaphoretic. They might have pulsus paradoxus. They quite likely will have a nocturnal cough or a normal cough. And don't forget that this disease is induced by exercise. So that's one of the key points to try to get across to your examiner, that you understand this disease. So you're telling him all these things, him or her, all these things about asthma, that it's diurnal in variation, etc., etc. So yes, there is a difference in how we treat acute versus chronic asthma. In the acute setting, you will always approach the patient with an ABCDE approach. You will give them oxygen and you will monitor their SATs. You will also apply other monitoring to the patient. Second thing you're going to do is do an ABG, and you quantify your problem. You look at the PO2 and the PCO2 on that gas. Also, you can look at other things if you fancy, such as the pH, the lactate, see what might be precipitating their acute asthmatic event. You also want to do a chest X-ray, and you want to get them to use a peak flow meter, and eventually you'll probably want them to do pulmonary function testing after that. In the chronic asthmatic, you're going to want them to have pulmonary function tests in a pulmonary function lab. You're going to give them a peak flow meter. You're going to test them for eosinophilia, which characterizes the disease. You might, if you are American, want to do a methacholine challenge, is where you give them a drug called methacholine that provokes their asthma to test if they really do have it. I'm not sure that I would maybe do that in the UK. It's not particularly common. And you might want to check their FBC or their CRP. And the purpose of checking their FBC is to see whether they have increased white cells or anything that is kicking off this chronic asthma state. So with exacerbations of asthma, you will get a respiratory alkalosis from the CO2 being blown off. The person's panting, trying to get oxygen in, and therefore liberating CO2 from their body at fast rates. So their CO2 dips, and you'll get an alkalotic picture because CO2 is an acid. Acidosis will be present in the patient. It's a very worrying sign. If the CO2 is building up, that means they're not ventilating. And if they have a high respiratory rate but their CO2 is high, there's something very wrong with the patient. Hypercapnia and hypoxia cause acidosis, and this can lead to cardiac arrest. To treat somebody with acute asthma, you will give them 100% oxygen. You will give them a beta-2 agonist such as salbutamol. You will give them an anticholinergic nebulizer such as ipratropium. Both salbutamol and ipratropium should be nebulized, and these can go back to back if you like. Would also consider giving the patients IV steroids that might start to work in about 12 to 24 hours, such as 100 to 200 milligrams of hydrocortisone, for example. Give them antibiotics if you suspect sepsis, IV fluids if they're hypotensive, and if the patient's about to crash, you might want to consider adrenaline, which is also a bronchodilator. The other drug that I have not written on this slide that's important is IV magnesium sulfate in the acutely deteriorating asthmatic, which is a bronchodilator. So in chronic asthmatics, you're going to be focused on the British Thoracic Society guidelines. That's going to guide your management in chronic asthmatics. Chronic asthmatics can present in any way in the hospital. Somebody who's in for an operation can have pre-existing asthma, or they could come in with a problem with their inhalers into primary care. You need to ensure there's no other cause of chronic asthma, such as GI reflux or gastroesophageal reflux disease, in which a PPI is indicated. The first step in the treatment of chronic asthma is a short-acting beta-2 agonist. You need to assess then whether they're taking more than 10 puffs a day of this. If they are, that's bad. You then need to add beclomethasone or a similar inhaled steroid and aim for 2 puffs a day. You can get localized side effects in the nasopharynx, the pharynx, the throat of candidiasis in these patients, and QVAR inhalers are quite good, and you should Google what a QVAR inhaler is. You should also Google inhalers and know how to explain what the different ones are and the different colours, like what's in a purple inhaler, what is serotype, etc. You should then consider the stepwise escalation to a long-acting beta-2 agonist such as salmeterol, then escalating onto a leukotriene receptor antagonist such as montelukast, which will reduce inflammation. And finally, you should consider oral steroids at the lowest dose possible, and that can be drugs such as prednisolone. And you should start at the lowest dose possible and then taper them off once the patient is able to come off the steroids. You don't want to keep patients at high dose long steroids, because this can cause insufficiency of their adrenal gland and can cause a Cushing out appearance and signs and symptoms. Excellent topics to talk about in your asthmatic final viva or whatever you're talking about to the examiner is you look at the inhaler technique, you talk about asthma diaries, you talk about how the patient can avoid precipitants of their asthma such as dust, etc. These patients have a history of atopic disease usually, so try to find out what their triggers are. Refer them to an asthma nurse or respiratory physician. This shows you've considered the multidisciplinary team. You can also even refer to chest physio. Another important thing to consider is that whilst you can go up and escalate your steps, you can also come back down in them. So if you've started somebody in steroids, you can de-escalate the patient. You can also take away things like montelukast. You can come right back down so the patient's over their initial bad flare of asthma and they're back down to just using a short-acting beta-2 agonist. So escalation and de-escalation of the pathway is important to consider. Very quickly now, I'm going to talk about Cartaginer syndrome. Cartaginer syndrome, I'm only really going to talk about the fact that it is a triad, and this can come up in MCQ questions, SBA questions, and it is characterised, once again, by a triad of primary ciliary dyskinesia. So your cilia are not working properly. You have situs inversus, so your organs are all the other way around, your liver's on your left, for example, and you've got sinus infections. If you fulfill all these unfortunate qualities, you will get bronchiectasis, which we'll talk about in a minute. This bronchiectasis is caused by Cartaginer syndrome. It is a triad, and they just love these eponymous syndromes, so just learn it. In an ever-increasing obese population, obstructive sleep apnea is becoming more and more common, and it is important you recognise that about 1% of men, probably more nowadays, experience obstructive sleep apnea that is diagnosed using sleep studies. They tend to desaturate at night and get nocturnal bradycardias that can wake them from their sleep. It is characterised by obese patients or oronasal anatomical factors in the patient. These patients will typically present to you in the hospital as a junior doctor, and they'll tell you they have CPAP at night. It's actually not for an underlying respiratory lung problem, it's because they have obstructive sleep apnea. If they do have this, and they do have their own CPAP machine at home, you ask them to bring it in so they can have it at night. And this can be multi-problematic for you in hospital. If you are going to have surgery post-op, you're likely to be loaded up with things like opiates, and your respiratory rate will go down with those. And if you have obstructive sleep apnea on top of that, whenever you're more drowsy, that is going to be a problem for you. So you need to get these patients to bring in their own CPAP machine at home, because you may not have a CPAP machine that is suited to them readily available in the hospital, or particularly the ones that just go around the nose. The treatment options for this are to lose weight, so you lose weight in the tissue in your oronasal anatomy, and you can also potentially have surgery on those oronasal anatomical factors, but this is not it's not going to be as good as losing weight. You test people for OSA by using polysomnography, which is sleep studies, and these patients will tend to have a thoraco-abdominal movement whenever they're breathing, and that's called a thoraco-abdominal movement paradox. These patients suffer from type 2 respiratory failure at night whenever their airways collapse down. So that's basically all you need to know about OSA. So because going forward, we're going to talk about a lot of different pulmonary function testing and what happens whenever they're low or high, we need to discern what pulmonary function testing is good for. It has three main functions. The first one is to discriminate restrictive versus obstructive lung pathologies. The second is to assess the severity of that lung pathology, and an example of that is a pre-op pulmonary function testing to see how good your lungs are before we stick you on a ventilator. And the third one is a post-treatment evaluation. So the drug efficacy, are the drugs you're giving the patient working? Is salbutamol working? Is there reversibility whenever you're giving long-term steroids? Is theophylline working? Etc., etc.